So next up, we have Rishi Lamichhane. Rishi is one of our research assistants here at NourishED. Not only that, Rishi is actually our first research assistant at NourishED, and I think our second staff member total, for which I'm so grateful. Rishi came on, right after we founded. I had a summer internship, kind of ad program, and Rishi reached out, was really interested in public health and biostats at the time. And as I shared in my presentation, I said, I only know enough biostats to teach my students. I think you probably know more than me already, which has proved to be true by a long shot. But I think I can mentor you in biostats. We're just so grateful. I'm so grateful to have you, Rishi. We've learned so much. I've learned so much. I think that you are working, so I don't think maybe caught I think you've seen my presentation before, but just the work that you've done and the perspective that you bring, it just really has helped to expand the way that we can communicate qualitative research, which I think is amazing. And I'll give it a little bit of a pause there. I'll just kind of add, so Rishi was recently accepted into Brown University in their Masters of Public Health. He's decided to defer for a year, which selfishly I love, means we get to a little bit more. And I'm leaving out so much. I'll turn the time over to you, and we're just so grateful to have you be here.
Thank you, Dr. Bray, for the introduction. Hi, everybody. My name is Rishi. I am a recent graduate from Springfield College in Springfield, Massachusetts. I did a double major in public health and computer science. And yeah, I'm just working full time for a year. That's why I deferred my admissions at Brown. I'll be joining there like next year, probably around like September. So I'm excited for that. I'll just share my presentation. Can you see it?
Yes.
Okay. So yeah, I am taking a gap year right now. I'm working full time in social work, and my plan for this year is to continuing doing research at NourishED and learn more and publish and do all good things. So today I will be presenting on well, my topic is connecting the dots. You'll know by the end of the presentation why it's called that. And this is since I joined NourishED for last year, around July. I've learned a lot in the process. I've discovered different ways to do qualitative research, like how to do better data visualization, which is something we need at this day and age, and also learn different techniques and different software, different programs to present qualitative data more effectively. So we'll be talking about that. Before diving into what my work majorly, let's talk a little bit about binge eating disorder. So binge eating disorder is basically autonomous eating disorder diagnosis recognized in DSM-5. It's characterized by episodes of eating objectively large amounts of food in discrete period of time. And it's also coupled with the sense of loss of control as well as significant distress after it. And this actually isn't rare. The lifetime prevalence of binge eating disorder is around 20%, meaning 20 out of 100 people have it. And that's a lot of people if you talk about it. So, and it does not exist in isolation. We have found that binge eating disorder exists with depression, anxiety, chronic illnesses such as cardiovascular diseases, obesity, diabetes, and so on. So it's very important to talk about it. Moving forward, we have some stats over here. So why is this work important? Like, it is backed up by the evidence and the data. As I mentioned, 1 out of 5 people have binge eating disorder at least once in their lifetime, among which 95% of it goes undetected and untreated, whereas treatment success isn't a lot. It's around 45%. It's less than 45%. And among those treatments, the reoccurrence happens 65% of the time. So we need a lot of work to do there, right? Moving forward, we have who experiences binge eating disorder. So We may see this a lot because this is the most research that's been done. It is not limited to skinny, white, affluent girls. Everybody suffers it, but in fact, the higher prevalence we can see is in BIPOC community, LGBTQ plus communities, and food insecure population. And yeah, there's a lot of stereotypes that it only occurs to skinny white girls, but that's because that is where we have most research. The research is lacking for underrepresented communities or like people of color, LGBTQ plus people. In fact, people who experience food insecurity are face like 2 to 3 times more rates of binge eating disorder, which is very alarming, and more work needs to be done in this area. So that's something Dr. Bray's research focuses on because it's about social justice as well. Moving forward, we have the gaps, of course. So there's research limited to treatment-seeking samples. The sample size is very limited, as well as the sample is very biased. So that's one thing that we see a lot of research gap on. We also see many complexity of environmental factors poorly captured. So we don't see a lot of environmental factors to begin with, but also if they do some research on environmental factors, there's something lacking, like they don't talk about how those factors are interrelated to each other, for instance, or how they can be visualized better so the public can look at the data and understand the data more clearly. And there's no clear way to visualize interrelated themes. So they just put all the themes in a linear sequence, but that is not how it works. Like all the themes are related to other themes and so on. So that is something we found research gaps on. Because the sample size is limited and the population is biased, we do see very low external validity. And then also, like, there's so many systemic and environmental factors that goes missing, or the interrelationship is not captured fully. So that's something we found is lacking in the research area. And moving forward, so talking about the solutions, we need free or low cost solutions. We need virtually accessible or community-based solutions. That's where public health comes in because it talks about community aspect. We need inclusive of marginalized group, both research and interventions, and it has to be free of stigma. It is very stigmatized. While I was making this presentation, I wanted to put some pictures that could be relevant to the issues, but either it was biased or it lacked representation online. So I was like, no, I'll just put like pictures that are relevant, like related, because I didn't find much. So there's a lot of stigma related to it too. Moving forward, we have the work that we did. So our approach was, the application was network mapping, or we called it thematic mapping to qualitative binge eating disorder data. The tools we used were Kumu and Python, and our goal was to visualize environmental factors. We'll get in depth about it. So the study data for the research I did was Bray et al. 2022, which was the primary research done by Dr. Bray. It's on social justice. And then here I have, so yeah, it was like a mixed method study conducted by Dr. Bray, and then it involved 14 internationally recognized binge eating disorder experts. It consisted of clinicians, researchers, healthcare administrators, and so on. And they were selected based on funding history, publication, leadership roles, and active practice. And then through semi-structured interview, they identified 12 major themes, and you'll keep hearing me repeat the word themes and sub-themes. So these themes are the themes from the research that was done by Dr. Bray and the team. And these 12 major themes are the environmental factors of binge eating disorder. I don't remember all the themes, so you have idea what I'm talking about. These include invalidation, systemic oppression, marginalization, economic insecurity, stigma, trauma, food and nutrition insecurity, interpersonal factors, social media, predatory food industry practices, and research or clinical gaps. So these were the 12 major themes that was found by Dr. Bray during the mixed method study. As I mentioned, moving forward, we're a mapping protocol. So this is where our work comes into existence. So we use two softwares. One was Kumu and the other one was Python. So Kumu, if we talk about Kumu, it was very user-friendly, interactive, accessible to non-technical users, or very limited coding, while Python was a little more advanced customization. We had different packages that we could use for better, like for different variety of visualization, and it did require coding expertise. As a student of computer science myself, it was still very difficult for me to do, so I do not see it accessible for many researchers. So we'll be talking about Kumu versus Python, which one worked better, what did we learn, what was the limitation of it, so we'll get into those things. First, I'll be talking about Kumu maps matrices. So Kumu applied these factors: betweenness, closeness, degree, eigenvector, in degree or out degree, and reach. So for instance, I'll show you the maps after this slide, but for instance, marginalization had the high betweenness, so it acts as a bridge. Systemic oppression has high closeness, which means it quickly connects to others, and invalidation has high eigenvector, meaning connected to other influential nodes. So let's see how that looks. So this is my first illustration. This map was generated by Kumu. Here we have binge eating disorder, and these are all the themes and sub-themes over here. Like everything is related to each other, but if you see those 100 percentages that are really close to binge eating disorder, so they're very close because they're endorsed by 100% of the 14 out of 14 subjects from the research. And then each of them are here. If you can see in the periphery, there are other sub-themes related to it. But if you can see, there's 93%, 93%, 79% are further from binge eating disorder, and 64% are like further than that. So if as someone who does not know much about like data visualization, or has not understood like binge eating disorder or environmental factors, and they don't know how environmental factors work together, interplay to cause binge eating disorder. Like when you look at this chart, like you will know instantly, like it's about binge eating disorder, and these four themes are the most important or most closely related, whereas the one further along are less interrelated with that. Like, so it makes the data visualization aspect of it very easier for anybody to understand. Like if I show it to my mother, like she will be able to grasp the concept of it, which is exactly what Dr. Bray and the team and I want, because there's so many environmental factors. And when I looked at the environmental factors, when I was talking to Dr. Bray in the beginning of the project, I was like, how can we visualize it better? Because there's so many things going on and I can't comprehend everything. Is there any way we can visualize it so everybody, despite their knowledge of binge eating disorder or this environmental factor, can understand? So that was our goal. So as illustration one, you can see how it's been perfectly laid out for anybody to understand. Here's illustration two. It has other factors, other related factors, such as mental health, physical health, social health, public health, and welfare, such as like this related factors, and they are surrounded by binge eating disorder and the 12 themes found by Dr. Bray's research. So this is also very effective in talking about how in public health classes I used to learn about how there's like your like individual factors and how there's overall like overarching factors that affect all the individuals or community. So this way we can look at those factors and add those factors. And one good thing about Kumu Map is how, so I'm showing you just the pictures or the PDF version of the Kumu Map. When you go to the Kumu Map and when you click on mental health, for instance, it'll show just mental health and what other things are related to, or it'll make the maps much simpler. So if we do like large scale projects or research, you might have a question that like, oh, like this looks too chaotic. Like, how can we visualize it better? But Kumu is interactive map. So that makes the job easier of like, for instance, like if you want something tiny, like food insecurity with a 64%, like you can click on food insecurities and it'll show you only the things that are related to food insecurity. So it also helps with that aspect, which is also something that we worked on, and Kumu is really good with that too. So I really appreciate how Kumu is very versatile. Like you can use it for if you want to make a map of your own social networks, you can do that. For instance, like a hierarchy of your organization, you can lay out CDO and staffs and all like hierarchy in your office. That's one aspect of it. You can do so much with Kumu. It's very versatile. I would definitely recommend you all use it. Moving forward, we have Python maps matrices, which talk about coding aspect of it. So Python, for this project, we use two packages, NetworkX and Matplotlib library. And then these definitely replicated Kumo findings in terms of interrelatedness or closeness, as well as there was a little more we could do with Python, like layout and edge direction and node sizing and those things. The central are invalidation, oppression, and marginalized population, as you'll see it in the next slide. And the peripheral are food industry and nutrition scarcity. So here, what is happening in this slide is, if you look at the central elements like research and clinical gaps or trauma and adversity, these are the themes that have most relationship with other themes in the research, whereas interpersonal factors, the one in the periphery, are the themes with less interrelatedness. Like they are related with some themes, but not all. Whereas like invalidating environment and experiences are almost related to all the themes. And that is one thing that was unique about Python, but it does require coding skills. And I do recognize that not a lot of people, like if it was very difficult for me to do as well. So if you are someone who loves coding and who knows Python, you can try this. There's multiple sources on internet. There's plenty resource, which I'll be happy to share with you if you want to learn. But if you're someone who wants something simpler and want dynamic visualization, I think Kumu is a better choice. For my last slides, I have so what and what's next. So what? This research makes complexity visible. As you saw how complex, like drawing out the qualitative research or mapping them is. It's very complicated, especially when you have too many themes and sub-themes going on in the research. So it makes complexity visible. Like you can look at it and you can understand, like skim through it and understand much of it. And it bridges qualitative and quantitative research, which is something we worked on because a lot of coding aspect, or we had to make a heat map to do the coding. So that was like the quant of the research that we did. So it bridges those two, qualitative and quant. So it's mixed method study. It can inform clinical care as well as public health and policy, because a lot of these environmental factors are policy based, or like they're like community based, like these are environmental factors. So they interplay with each other, they're connected to each other. So it can inform the public who don't know much about the data or the subject to look at it and understand it. So that is basically the implications of it. Talking about what next, there's a lot of project that we'll be doing in days to come. I'm super excited for it. I have plenty of time in my plate to start new projects and continue with this project. So our plan is maybe in near future, if we have patient data, like a lot of like large scale study can be done. That was the expertise perception. We can also apply this to patients' perceptions as opposed to just expert views. We can do treatment access barriers. We can do systematic reviews of binge eating disorder and environmental factors and so much more, and apply social network mapping or thematic mapping to those studies that we do in future. So that's one of the projects that I'm really keen on doing. So I'm excited to do those. So yeah, those are some of the things that I want to be doing in future. Hopefully in our next summit, you'll get to hear more on that. And that is all I have today. If you have any question, me and Dr. Bray both can answer it for you. Yeah, thank you.
Thank you so much, Rishi. I did put links in the comments to the primary data, so to my 2022 publication, and then to Kumu as well. And if there are any questions, feel free to throw them in the comments, or just kind of raise a hand on Zoom. And I thought I'd share. Rishi was kind enough to kind of hold some space for me to share. I kind of glazed over in my own presentation. So I thought I'd just kind of share for those who were on this morning or maybe weren't, a little bit more of like how we really incorporate this into kind of the broader picture, which Rishi, you did a fantastic job of sharing as well. So grateful. Um, so I'll do a quick screen share here. And if anyone, don't need to wait. If you have any questions in the chat, feel free to throw those in. Um, let's see. Okay, it's gonna be, just give me a second. Here we go. Okay, perfect. Okay, and I'm going to turn my video off. Is everyone seeing my screen? Yeah, cool. Okay. Um, so Well, I kind of mentioned in my presentation, so here's some of the themes that Rishi mentioned that we found. So systemic oppression, food, nutrition insecurity, predatory food industry practices, and actually let me go back to, yeah, here's where I wanted to start. So the percentages that you're seeing in parentheses here are the percent of participants who endorsed this theme spontaneously. So they described this theme. I didn't ask them about it. They weren't prompted. These were just really the themes that experts associated with binge eating disorder. And so systemic issues and systematic oppression, marginalization, which included lack of access to resources. I just couldn't fit that all on, in one, what's the word I'm looking for here? One line. Research, so gaps in clinical research and clinical care, invalidation, invalidating environments and experiences. Those themes were identified by all experts in our study. Stigmatization and discrimination, economic precarity, trauma and adversity, food insecurity, interpersonal factors, social messaging and social media, nutrition scarcity, and then predatory food industry practices and environments. And out of those, that last one was actually the only one that I had anticipated. So here we've got our themes, and we published this data in 2022. Qualitative data can be really difficult to communicate. Kind of the best tools that I had was reading quotes, showing quotes, and it was kind of an eyesore on a presentation. And so we had, very gratefully, both Rishi and Barbara Kalu, who is another one of our, actually, let me actually go backwards here in my slide set if I can. Um, Yeah, here we go. So Barbara Kalu is a clinical mental health counseling master's student at Johns Hopkins. Barbara was our third staff member, so she came on very shortly after Rishi. And, again, getting her master's in clinical mental health, and has managed our social media and kind of social marketing team, and has really been our social media and social marketing team. And she's developed these beautiful infographics like this one that you're seeing here that really can enable me and others at Nourish to present this data in a way that can tell a story, and it's not an eyesore. So here we're just kind of seeing that binge eating disorder often is just the tip of the iceberg. And there's all these environmental factors that often go unnoticed, unrepresented, and overlooked, particularly in clinical care. But as we've kind of heard throughout the day today, are really important to address for a variety of different reasons. So these infographics have been really helpful in communicating qualitative data and mixed methods data. And then, of course, Rishi's work has really enabled us to take this one step further, and in mixed methods research, where we have qualitative and quantitative components. I think that this way of communicating this data is just brilliant. As said, it really enables us to communicate the complexity, the way that all of these themes and sub-themes and really, factors are connected to one another. And another thing that's really cool is with Kumu in particular, is that it offers us some social networking tools to conduct kind of social networking analyses. And again, Rishi, did a fantastic job of sharing this. So the way that I kind of think about this data is, we have the kind of biopsychosocial theory, or construct. So we can kind of place these domains, mental health, physical health, social health, which I would really call public health and social welfare. And when I kind of started looking at this data after Rishi had set everything up for us in Kumu, so I added in these themes. I added in binge eating disorder, of course, as our center. Then I added in this kind of field of psychoneuroendoimmunomicrobiology. Now, that's a big mouthful, but it really describes a variety of different markers that we can use to assess ways in which the brain, the stress system, the immune system, or the gut might become dysregulated. And also nods to the fact that these are all related. So changes in the gut can result in changes in the immune system and the immune response, changes in the stress system and the stress response, changes in the brain functioning and cognition. And likewise, changes in the stress system can cause all these other changes. Changes in immune function can cause all these other changes. And they're absolutely linked, not just to mental health, but also to physical health and to social health. And I talked about this, quite a bit in my talk. PJ did a really beautiful job of demonstrating this, right? The way that these social factors can impact our physical health and our mental health because they really are all related. And that's not just a woo-woo concept. We have really solid empirical data to show that these systems are all linked, right? So I just kind of threw that in there. Um, and then, just as Rishi showed, started kind of adding in, the different themes. So here we've got gaps in clinical research and care, invalidation, marginalization, systemic oppression, economic insecurity, food insecurity, or economic precarity, food insecurity, nutrition scarcity, stigmatization, interpersonal factors, social media and messaging, trauma and adversity, and food, predatory food industry practices. And as you can see, these are all more social issues, which is why my 2022 publication was titled Binge Eating Disorder is a Social Justice Issue. So the environmental factors that experts associate with binge eating disorder are social justice issues largely. So we kind of plotted that out. And then I kind of separated these so that you can just see all the different connections. We mapped in Kumu, you kind of, add in your themes or elements, almost on like it's not an Excel spreadsheet, but it's very similar to that. And then you can add in your connections. So we added in all the connections as they were described as being connected by experts in my 2022 publication. You can just see these are all really interrelated. Then, Rishi kind of showed this slide. We took out that construct and just showed how these themes are related to one another. Again, just so you can get a feel for all of the connections that exist between these. And then we added in our sub themes, which can make things get really messy really quickly, right? But I think a better word for messy is complex. These things are very complex and they're very highly nuanced, and we can see COVID-19 pandemic, taking patient narratives, insurance systems, eating disorder research as a field, stigmatization in healthcare systems, federal funding for eating disorder research, interpersonal deficits, body weight, shape, size. It goes on reward dysregulation, the food industry, nutrition scarcity, down here, we have different factors of marginalization. So we've got discrimination, the male sex or gender orientation, age, religion, BIPOC community members, LGBTQ2 plus community members. So it just gives us a really colors in the picture, and accounts for all of these different shades and colors that this really isn't just a black and white kind of binary issue. So then we scope back out and show that within our framework. Again, we're just really seeing these are largely kind of social justice issues. Here we've got the COVID-19 pandemic, which kind of offers, both social and physical as well as mental health. Really, all of these would fall right here in the center where we're seeing binge eating disorder. Played around with that a little bit, kind of did some different configurations, which is really amazing that Kumu allows us to do. Took the center binge eating disorder out and just showed these themes relating to one another. And then we get into this really cool kind of these social networking analyses that we can do. So the first one that we did, and this is where I didn't, Rishi's been so kind to enable me some time to kind of elaborate on this. Um, so Kumu offers these really cool tools. So we have matrix of cross-impact multiplications applied to classification, which we just abbreviate as MICMAC for short. Most people just know this as MICMAC. MICMAC is a system analysis metric that explores element exposure and influence. The elements in this case are our themes and sub-themes here. So we can look at in these themes and sub-themes, how exposed they are. So how much one element is affected by another element. We can look at how resilient they are, and we can also look at their influence. So how much a single element affects other elements in the system. So when plotted on an XY axis, these scores can help identify potential leverage points within the overall system. So we really wanted to focus here on the MICMAC influence, the extent to which one element, theme, or sub-theme can influence other themes or sub-themes in the system, as well as the system as a whole, right? If our goal is to help improve outcomes, reduce prevalence rates for binge eating disorder, then it behooves us to know which of these elements might hold the most influence, kind of have the biggest bang for our buck, so to speak. So when we're looking at MICMAC influence, high values indicate high leverage with the changes kind of rippling outward. And what we see just when we're looking at influence is that we get a little bit of a different story here. So systematic oppression and systematic gaps was found in this analysis to have the highest MICMAC influence, which aligns with its endorsement. Experts kind of gave this 100, all experts endorsed this theme, and it was largely the most predominant theme that I identified. Justice in legal systems, which only one expert identified, so it only had 7% expert endorsement, was recognized as having the second highest MICMAC influence. That aligns with kind of my analysis. Remember the publication was titled Binge Eating Disorder as a Social Justice Issue. So it really, in kind of a unique way, accounts for the impacts that social justice have on binge eating disorder. Then we see economic insecurity, insurance systems, which again, only 64% of experts identified as being relevant to binge eating disorder, but has a MICMAC factor of 0.85. Predatory food industry practices, interpersonal relating. So these top five here, they're all really, again, social justice issues, and they're systemic. They're systems, right? So after I looked at this, I went through and just, subjectively highlighted which of these elements might have greater feasibility for change. Where if we're wanting to invest resources into changing the system, where might those resources be best spent? So the first one is insurance systems, which, at Nourish, this is not something that we are, I would say we're not experts in this. We don't interact with insurance systems, but I do hear a lot of our partners talking about insurance systems and insurance coverage compensation. I happen to work in the emergency department in the medical scribe industry for over 10 years. So I do have a little bit of a, kind of adjacent interaction with insurance systems. But our partners at Project Heal work with care coordination. They work with insurance systems quite a bit. So I just want to really underscore here, insurance systems are a really important piece in binge eating disorder healing and in the prevalence of binge eating disorder. food industry, predatory food industry practices. We had David Bryant come speak Friday evening, on the legal side of food systems and food regulations. And, so that's again, it's one that I wouldn't say that us at Nourished have a huge ability to impact change, but it is one that is a little bit more malleable, I'd say, and where there are folks really working to impact change there. Then we have interpersonal relating, and I kind of, as Rishi shared and as I mentioned, interpersonal therapy is one of two recommended psychotherapies that are guideline, according to APA guidelines for binge eating disorder, right? So interpersonal relating is a big one. We also had Matthew Hicks share findings yesterday on findings from his feasibility study on group psilocybin assisted therapy. And one of the things that he said was folks reported feeling more comfortable in interpersonal relations, right? And he kind of shared on the elements that the group aspect of the psilocybin assisted therapy had, but a lot of that was attributed to the psilocybin, the medicine itself. Then we have nutrition scarcity, right? And so often when folks have low socioeconomic status, um, maybe they're, and, as well as geographic systems, maybe they're living in food deserts where they don't have access to, good high quality, good nutrition. Folks who have low socioeconomic status, often, organic fruits and vegetables are more expensive. If you live in a food desert, then having access to those foods requires time, transportation, resources. And then folks, who are reliant on government assistance, oftentimes the foods that you find in food pantries and through food stamps and things, not through food stamps, but food pantries, maybe they're not always the most nutritious foods, right? You might want foods with higher shelf life. I offer, frozen foods can do that as well, but when we're thinking about foods that are more shelf stable, those are often highly processed foods and they often have low nutritional density. So just kind of really trying to help work with folks with low socioeconomic status and find solutions that are still nutritious is something that we do really value at Nourished. And we've actually put in a grant earlier this year that we didn't get. Unfortunately, there were a lot of grants going in, but we've put in grants to help try to work with food pantries to offer nutrition counseling to folks using food pantries, things like this. This is something that I think is really important. And then, school systems, sex, gender identity, those really aren't things that we can't really change school systems. Federal funding for binge eating disorder research. Again, that's not one that we have much control over, but it is one that's really important. And then addressing gaps in clinical research and care. And so for us at Nourish, this is where we really, kind of come in, where we can kind of try to address these gaps in clinical research, clinical care. And again, we're coming in at the element that is like 11th on the list of MICMAC influence, but it's where we can come in really, right? And then down here, again, 15th, stigmatization in healthcare systems. And again, this is something we really prioritize at Nourished. We do offer trainings as well as resources for healthcare providers, healthcare organizations, and administrations. So if you're a provider, and maybe you have a patient who has high weight, and you think that that's really important to discuss because it increases their risk for cardiometabolic disease, hyperlipidemia, hypertension, hypercholesterolemia. As I mentioned, Philippe Hay does have some work showing that overweight and obesity don't necessarily increase health risk in folks with binge eating disorder. But if, for many it does. And if that is important for you to address, we offer some tools and some support on how you can address that, knowing that you're going to be encroaching, you're going to be walking on a landmine of trauma often. So how you can have those conversations while still, holding your patient's humanity kind of first and foremost, and being really trauma informed around that. So that's MICMAC influence. How are we doing on time here? Does anyone mind just unmuting and letting me know what time it is? I'm not able to see a time.
It's 5:38.
Oh, perfect. Thank you. So we've got a little bit more. So that's MICMAC influence. And then we can also look at outdegree. So outdegree measures the number of outgoing connections for an element. And again, an element in this case would be a theme or a subtheme. In general, elements with higher outdegree can reach a higher number of other elements, themes, subthemes, and spark the flow of information across a network. They may not be the most efficient at spreading the information, but they have the most outgoing sources, right? So this might be like your gossip element or theme. So basically, outdegree is the number of outgoing connections. Higher values are going to indicate that the element actively influences others. So it suggests a strong candidate for change, as does MICMAC influence. When we look at outdegree or outgoing connections, we see that the elements, themes, subthemes with the highest outdegree are again systemic oppression and systematic gaps, which also had the highest MICMAC influence, was endorsed by 100% of experts without prompting, has 39 outgoing connections. Then marginalization, which also was endorsed by 100% of experts, has 31 outgoing connections. So this would be, individuals of marginalized communities, a lack of access to resources, things like this. Then invalidation, stigmatization in healthcare systems, and gaps in clinical research and care. And then the list goes down here. Now, if we look at this list of outdegree connections and we look at which of these elements maybe have higher feasibility for change, this looks a little bit more positive for us, right? So stigmatization in healthcare systems, as I've already named, is something that we really prioritize at Nourished, and this ranks fourth on the list of outdegree or outgoing connections. Gaps in clinical research and care as well, something we really, prioritize and address at Nourished. And this is fifth on the list. So that's, pretty hopeful. And then we see the predatory food industry practices. I tend to shy away from this one a little bit at Nourished. I think that it is really important. It also gets very highly socio-political, and it's can be a concept that's more polarized in the field. It's one that I value deeply, 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 and I think that it is so important. We tend to address it less at Nourished. I'll just kind of name that, but it is really important, and it's six on the outdegree list. Then if we kind of look lower, body weight, shape, size, bias, which kind of goes along with stigmatization, is 11th on the list. That also is something that we, really prioritize at Nourished. And then 15th, call for public education. And as I mentioned, we really prioritize our social media presence at Nourished, and kind of using social media campaigns to help change the environments that eating disorders occur in. So that's kind of an alignment there. So that was kind of reassuring for us, for me, for us at Nourished, to see that we really are kind of investing our resources, right where we might want to be or should be. But these tools are just so helpful. And I'll go on. I just want to add here, Rishi kind of named that, we're getting ready to put out a publication on treatment access barriers. And then Rishi is going to kind of apply the same network mapping protocol and the social network analyses here. So it makes me really excited. I think the last analysis metric that I'll show is reach efficiency. So Kumu offers, the metrics that they offer in their social network analyses are amazing and quite robust. I think there's maybe somewhere between, 15, if I'm guessing, different metrics. Reach is one of them, and I won't show reach, but I'll describe it, and then we'll talk more about reach efficiency. So reach measures the portion of the network that are within 2 steps of an element. So if we're looking at, gaps in clinical research and care, we're seeing 1, 2, 3, 4, 5, maybe outgoing, immediate primary connections. And then if we were to follow that through and say, okay, well, gaps in clinical research and care links, it has a connection to marginalization. And then how many links does marginalization have? Marginalization has 1,000,000 links, right? So that would be reach, is how much of the network is within 2 connections of this element. Reach efficiency normalizes reach by dividing it by size or the number of neighbors. So in general, elements with high reach efficiency are going to be less connected, but gain more exposure throughout each direct relationship. So reach efficiency is reach divided by size. It measures influence per connection. Higher values are going to indicate efficient influence with few but powerful links. And when we look at reach efficiency, we're getting a little bit of a different story here. So insurance systems comes out as having actually the highest reach efficiency with a value of 0.12. And again, that was endorsed by just 64% of experts, so over half. But I think, often that is overlooked. And I'll just kind of name in research, there's a large, I think, percentage of folks who are clinical researchers, who they have a clinical practice and they also do research. But in the field, and I think this is true of research in general, we also have a lot of researchers who are not clinicians, and we don't really work with insurance systems. So it can be easy to overlook that piece. But what we're seeing is that's a really important piece, and it has the most efficient reach. So insurance systems, urbanization factors, which I think PJ did such a beautiful job of speaking to. We actually had one expert who mentioned urbanization factors as an environmental factor. But here we're seeing it has very high reach efficiency of 0.11. Trauma and adversity, male sex or gender, federal funding for binge eating disorder research. So these were the top five. And then again, if we look at which of these elements have, maybe high feasibility that we can maybe change, we're seeing federal funding for binge eating disorder research comes in fifth, call for public education here comes in ninth, eating disorder research as a field. So, kind of dismantling the swag stereotype and the anorexocentric thinking in the field of eating disorder research, having more inclusive research. That's one that we deeply prioritize at Nourished. And then childhood adverse food experiences. I kind of talk to the work that we do, in trying to increase nutrition access in food pantries, things like this, and then nutrition scarcity. And I think I will pause it there and